are excited to start our last oral session on ART and metabolism, and we have 4 exciting speakers, and we'll do a question and answer afterwards, and then move on to the poster session and the mixers. So it's been an exciting day with excellent presentations throughout the day. Today as we start our last one, Wendy Fujita is going to go first, talking about substance use and treatment utilization among women of reproductive age with and without HIV in the southern United States. Whoops, is that right? Yes. Okay.
You got it.
You're on. All right.
Great. You got it.
All right. Hi, everyone. Welcome to the last session for today. My name is Wendy Fujita. I'm a 4th-year ID fellow at Emory, and I'm presenting some of our work also from the STAR data, well represented today, called Substance Use Treatment Utilization Among Women of Reproductive Age with and Without HIV in the Southern U.S. I have no disclosures. For background, nearly half of people living with HIV report current substance use. And we know that substance use and comorbid HIV is associated with worse outcomes along the HIV care continuum, including reduced rates of linkage and retention in HIV care, reduced initiation and adherence to antiretrovirals, and reduced rates of viral suppression. So if we're serious about ending the HIV epidemic, we need to also address substance use, which may facilitate HIV prevention and treatment and improve HIV care continuum outcomes. Now, when it comes to women with HIV and concurrent substance use, they have unique health needs. Women with both HIV and substance use have lower ARV uptake, faster disease progression, and higher mortality when compared to women with HIV without substance use or men with HIV and substance use. And some of the unique barriers to treatment that they may have are increased stigma compared to men, fear of intimate partner violence, the risk of losing parental custody if they have children, and again, if they have children, the lack of child care, transportation, or housing while supporting children may make it difficult to seek care. And then to take it one step further, for women or people who may be pregnant, there may be hesitancy or discomfort from a clinician standpoint to treat pregnant people with substance use disorders, so they fall into this gap because OBs may not feel comfortable treating addiction, and addiction specialists may not feel comfortable treating pregnant people. And then lastly, there may be fear of criminal punishment or other punitive measures because, as you can see here on the right, in the states that are red, if you use substances while pregnant, this is considered to be child abuse. And so collectively, we need gender-specific interventions to improve substance use care for women with HIV. This report that was published in JAMA last year showed that among about 7,600 people with pregnancy-associated deaths between 2017 and 2020, nearly 15% were related to overdose deaths. And there was an 81% increase between 2017 and 2020. And the highest overdose mortality rates were seen in those identified as late postpartum, which is shown in the blue dots, and this is defined as anything from 6 weeks to a year out from giving birth. So just one last slide on background, some prior work that we did using data from the WISE, or the Women's Interagency HIV Study. We looked at substance use treatment utilization among women with and without HIV in the WISE cohort. And what we found is that in this cohort of majority non-Hispanic Black women over 50 years old, current substance use was high at 14%, and I've defined these below, but I'll also reiterate them in some coming slides because they're the same definitions we used for the STAR cohort. And substance use treatment utilization was higher than what we anticipated at 42% among those with current substance use. And just for reference, the lifetime substance use treatment in the US is anywhere between 10 and 30%, so this was higher than we expected. However, this was largely driven by methadone and as the most frequently used treatment, and all the other treatment modalities were less than 15% utilization. And compared to methadone, buprenorphine uptake was disproportionately low. Now, one limitation of this study and our findings was that the mean age was over 50 years old, and so these results were not necessarily generalizable to younger women of reproductive age, and so that sets the scene for our results and our study using the STAR cohort. So my objectives here were to characterize current substance use among women of reproductive age with and at risk for HIV, and to evaluate the prevalence of substance use treatment utilization among these women with current substance use. And so what I'm presenting today is really research in progress and just some descriptive findings so far. You've heard a lot about the STAR cohort, so I don't need to reiterate this, but these are, again, the sites in the southern US. And for my methods, I included baseline data from all participants from 6 sites from 2021 to 2022, and our cutoff was March, so the numbers that you'll see here are a little bit smaller than what was presented earlier. The primary outcome for AIM-1 was current substance use, and this was self-reported non-medical drug use in the past year, including these substances. So I did not include marijuana, which exclusive marijuana use has not been shown to have worse HIV-related outcomes. And you'll see that tobacco and alcohol, which are very important substances, were not included here because I wanted to focus on what we colloquially know as drugs. For my AIM-2 substance use treatment, was any treatment in the past year among those with current substance use, and this was also self-reported. We conceptualized treatment broadly, so this included things like inpatient and outpatient detox programs, halfway houses, prison or jail-based programs, Narcotics Anonymous or NA, and medications for opioid use disorder, including methadone and buprenorphine naloxone, also known as Suboxone. And then we just assessed the proportion of substance use in treatment among participants, and I stratified by current or recent pregnancy, as defined as a pregnancy outcome in the last 2 years, and then also compared treatment or looked at treatment by HIV status. So in terms of our results, we included 519 women, and again, this was as of March of this year. The median age was 36 years, 75% self-identified as non-Hispanic Black, race or ethnicity, 11% were currently pregnant, an additional 11% were recently pregnant in the past 2 years, and a little over half reported taking care of children in their household. So for AIM-1, in terms of current substance use, among those 519 women, 63 or 12% reported current substance use. In terms of the types of substances used, crack and cocaine were the most frequently used substances that you can see on the left, followed by benzos and barbiturates. To the right of the vertical line are not the primary outcome, but some other covariates, and you can see there were also high rates, over 60% of concurrent marijuana use, and then about a quarter of people reporting current substance use also had daily alcohol use. Now, just looking at this side by side with WISE, the aim was not to compare STAR and WISE, but luckily, as presented earlier, a lot of the questionnaires in STAR are the same or similar questionnaires as WISE, so it allowed us the opportunity to just look at these results side by side. And you can see that in terms of the types of substances used, crack and cocaine were the most frequently used in both cohorts. But you can see in the gold bar that opioids, there was a much higher frequency of use among the WISE cohort. I will point out that it's not just the age difference, but there is also a geographic difference, and STAR is restricted to the southern sites. And then looking to the right of the bar, again, there's much higher rates of tobacco use in the WISE cohort. So going back to this slide, again, here are the women who reported current substance use. Among the 63, 12 were either currently pregnant or recently pregnant. And among those, 12 women, or 19%, reported getting any treatment in the past year. This included 3 out of the 12 women who used substances who were pregnant or currently pregnant who got treatment, and then 8 out of the 49 who were not pregnant or recently pregnant who had received treatment. 2 in total, we didn't know their pregnancy status. Then looking by HIV status, in the blue dots are women who were HIV seropositive, and in yellow are women living without HIV. And 25% of the women living with HIV had received treatment in the past year, and 11% of the women without HIV who were using substances received treatment in the past year. However, there was no statistical significance, and also with these subgroups, the sample sizes were quite small, so it limited our ability to make meaningful comparisons in the groups. In terms of the types of treatment, you can see here that the numbers are small, the absolute numbers. There were only 12 women who had received treatment. Inpatient detox and NA, Narcotics Anonymous, were the most frequently used substances. Notably, none of them had reported any methadone treatment, and there were a couple who reported Suboxone treatment. And again, looking side by side with our prior results out of the WISE cohort, you can see, first of all, that there was much lower rates of treatment among the women in STAR compared to WISE, which was 42%. And the other striking difference I thought was that methadone use was much higher in the WISE cohort. And we don't know the reasons, but some things that we postulated were, it could be possible that the WISE women who were on methadone actually had well-treated opioid use disorder who are now reporting, for example, stimulant use, and that wasn't being captured. Or could this be preferences because methadone has been around for a lot longer as an FDA-approved treatment? We're not sure, but we think those would be some interesting things to look at. Some of the limitations include the sample size of the subgroups, which limited meaningful comparisons, but enrollment is ongoing, and we're hoping to continue to look at these results as our sample size increases. Because of the way these questions are asked in surveys, there may be response bias or desirability bias leading to potential misclassification. And then unfortunately, we're unable to distinguish substance use from true substance use disorders as defined by the DSM criteria. However, the current follow-up questionnaires do include the DAST-10 or the drug abuse screening test, which we'll be able to include in future data sets. So in conclusion, in STAR, a contemporary cohort of reproductive women with and without HIV in the southern US, current substance use was common. However, fewer than a quarter utilized treatment irrespective of HIV status. And substance use treatment was lower than what was previously reported from demographically similar women who are over 50 years old. And this could reflect potentially different treatment preferences in different groups, or it could reflect different barriers to accessing care among different groups of women. In terms of future directions, we're, again, hoping to include additional, I shouldn't say waves, but include additional enrollment, which will increase the sample size and allow us to continue stratifying by pregnancy status and HIV serostatus. In our prior work with WISE, we used regression models to look at factors associated with substance use and treatment, which we're hoping to do, again, with the STAR cohort. And then we're also hoping to include not just drugs, but also alcohol use and alcohol use treatment. Unfortunately, in the STAR surveys, it didn't look like they asked about tobacco use treatment, is my understanding, so we're not going to be able to look at that. And so with that, I'll say thank you to the whole STAR team, including my primary mentor, Nandi Sheth, and the rest of the STAR site PIs and partners, and then the Emory ID Fellowship and the CFAR. Thank you.
Thank you, Wendy, for that very nice presentation. So our next speaker is Mandy Hill. Mandy is professor and director of population health and emergency medicine at the University of Texas Health Science Center in Houston. And she is going to be talking about findings from a social media campaign using video logs to enhance HIV PrEP access to cisgender Black women in Harris County. Thanks.
These aren't my slides.
Oh, I'm sorry.
There we go. Thank you. Okay. Hello, everyone. As she stated, my presentation today, I will be sharing with you findings from a social media campaign that we conducted with a uniform purpose of increasing access to local PrEP resources in Houston, Harris County. You may know this is one of the ending the HIV epidemic jurisdictions, hotspots, priority areas. I do have a few disclosures that's not on the slide. I am the recipient of 2 Investigator Research Awards, one from Gilead Sciences that ended in December of 2021, one that's ongoing that will end at the end of this month. So as we talked about when we spoke about maternal morbidities with HIV-positive populations, we know there is a disproportionate burden of new HIV cases with cisgender Black African-American women. And given this disproportionate incidence, this justifies our focus on intervening with women to try to prevent new HIV cases. So we need interventions that can bridge the link between knowing that PrEP, pre-exposure prophylaxis, prevents HIV, as well as motivation to access PrEP among Black women. Those strategies have to be engaging and relevant in order for women to be inspired to actually use pre-exposure prophylaxis. So we tried to design something that was engaging and relevant. We created video logs. We know a lot of us, we scroll social media, we see videos all of the time. So in 2019, Dr. Sandra Coker, who then was my medical student and is now my fellow faculty member in emergency medicine at UT Health, we came together and we utilized her experience with blogging and my experience with HIV prevention to design a pilot study that we call Debunking Myths. So the purpose of this pilot study was to educate cisgender Black women during an emergency department visit about ways that HIV and STIs are transmitted. But we wanted to debunk myths that are culturally rooted and believed as truth. One of those myths, I know I'm on the West Coast, so you may not know it, but there's a saying that old men give you worms. Has anyone ever heard that? Old men give you, do you see my fellow community members shaking their head? Well, that myth was actually used to protect young girls from being in vulnerable positions with older men. So it incited fear, but the purpose of that fear was to offer protection. So we have some of these myths that are just ingrained as truth. I can say when I was younger and dating, I didn't date older guys because I learned that old men give you worms, even though I know scientifically that isn't true. But in order to really drive motivation for behavior change, we have to address some of those myths and dispel them. So we designed this study. We utilized two educational strategies. One referred to as storytelling. As you can see, the young ladies are having a conversation. They're presenting myths as facts, and one person is correcting the other. So we wanted to see, with this casual way of debunking myths, increase knowledge with accuracy about how HIV and STIs are transmitted. And the second strategy, we called it taboo. So the young lady in red, well, this is Sandra. She would present the information as though it was a fact. If she was correct, we would hear a ding, and she would make a facial expression showing she knows she's right. If she was wrong, a bonker sound, bump, would come on, a GIF would pop up in the middle of her face, and she would appear in a lampshade to her right with a white coat and a stethoscope, because we know provider recommendations are very effective at motivating behavior and providing correct information. And so we compared both strategies to see which one did a better job at debunking myths about how HIV and STIs are transmitted. So our hypothesis was that storytelling would be more effective. We engaged 26 cisgender Black women who were ages 18 to 45 years. They were all sexually active within the last 3 months. We did enrollments at 2 local emergency departments, and we only engaged women who were there with non-emergent conditions, because for us it's really important not to interrupt clinical care for acute cases. So our study procedures included pre-screening for eligibility, consent, pre-test. We did randomization through REDCap. The young ladies would receive a tablet device to view the vlog. Then we would do a post-test, and then a gift card was rendered. So we did see that the study was feasible and acceptable. The women engaged readily with the tablet. They were having full-on conversations with Teresa and Sandra as though they were in the room. It was very, very entertaining. So our goal of designing new approaches that are engaging and relevant was shown because we saw how readily they engaged. And the process only took 15 to 20 minutes. And we realized, even though our study did not increase knowledge in the way we expected, we realized our research modality of using video logs had substance. So we repurposed it, and we submitted an application to the Texas Development Center for AIDS Research with 2 aims: to develop and implement a social media campaign using culturally competent and relevant video logs that we already had, and to circulate it in Harris County and in Houston. Our second aim was to evaluate the performance of the social media campaign by assessing primary and secondary outcomes that included key performance indicators, engagement with the campaign, the reach to Black women, community engagement, and of course, quantity of the vlog material that was actually consumed. These aims are complete. Here is a picture on the right of what the actual ad looked like on social media with our target population. And our purpose here was to share information about ways to prevent HIV and sexually transmitted infections using PrEP and fact-based information. So we took snippets from those original 10 to 11-minute vlogs. We created 5 snippets that were all around 30 seconds long. Our strategy targeted people who identified as female in their social media profiles. They were between ages that should be 18 and 55 years. And they use content or consume content that's usually consumed by Black women. So between our submission and implementation, social media, Facebook and Instagram removed race as a way to target the population. So we had to be a little innovative. And so as an indirect measure, we used zip codes in predominantly Black and African American neighborhoods in Houston-Harris County to try and capture cisgender Black women. So we launched a 6-month social media campaign where community members saw those brief snippets of the vlogs along with a brief message about PrEP with active links to local PrEP resources. And so this happened between March 2023 and September 2023. As I mentioned, we have 5 vlog snippets, and so over time, low-functioning ads, meaning those with less engagement, were removed in an iterative fashion, meaning the least performing one was removed one at a time, and only 2 vlogs remained after 30 to 60 days of running the campaign. And the campaign ended on September 8th, 2023. So here are our results. The link clicks were those who saw the video, they clicked on the ad, and then they clicked on the ad to see the list of local PrEP clinics and possibly navigate to those PrEP clinics. And we had almost 6,000. As you can see, the amount spent, this campaign cost us over $7,000. So it is an expensive endeavor. As you can see, over time, between March 1st and August 28th, with this snippet, we had a break with that red arrow, and we consider this a protocol deviation, although the IRB said this was not research because we were not engaging individual human subjects. But this break in the campaign was because of an error with a payment. We just could not move forward. We tried to engage Facebook and Instagram. We were not getting a response. And our social media ad expert was out of the country. So we had to wait until he returned. Okay, so you can see here that for those who engaged most readily with the campaign, they were between 18 and 24 years of age. We were targeting females, and as you can see, that target worked. We have 0% men who were actually engaged in the campaign. And so here we're looking at reach. And by age, those who were reached the most were between 18 and 34 years of age. And reach in social media terms are the number of accounts that saw the ads at least once. And here we look at impressions, which are the number of times the ads were on screen. And again, we see higher utility with those who were 18 to 24 years of age. So here are the overall summary of the numbers. We had over 1 million impressions. We had 976,125 video plays, over 24,000 through plays, and these are the number of times the video was paid to completion or at least 15 seconds of the 30-second video. And we reached 110,000 unique individuals. These are the number of accounts that saw your ad at least once. And again, with that group that's 18 to 34 years of age, we had the most video plays with this cohort. For those who watched the overall video out of 1 million, only 14,747 watched all 30 seconds of the video. So we do have some limitations, as I mentioned, with the inclusion criteria. The inability to target by race, ethnicity limited our ability to ensure that we reach cisgender Black women. So as an alternative strategy, we created a brief demographic survey that could be clicked on from that landing page with a list of the PrEP clinics. Only 15 people completed our survey. However, 66.67% of those who did complete it self-reported that they were Black or African American. So that gives us some confidence that we were able to reach Black and African American women by targeting through zip codes. So in conclusion, our social media campaign was successful at engaging the population. Some viewers did click on the web links to learn more about PrEP clinics and gain access to PrEP resources. And our findings suggest that the campaign successfully engaged the population, and these are all the ways that it engaged them, through Facebook and Instagram Reels, stories, feeds, and without targeting specifically race and ethnicity. So in the future, for those of you who may be considering a social media campaign, we do want to raise the attention for the cost. This is something you would definitely want to put in your budget and have enough funds for, and the age group. So although we targeted those who are 18 to 55, in the next iteration, we will likely target those who engage the most, which were those who were between 18 and 34 years of age. And this is our amazing research team. We have Sarah Sapp, our former research coordinator, who is now a medical student in Austin. Tristan Sutton, this is our amazing social media ad expert who was out of the country. We have Dr. Sandra Coker, who is now assistant professor and still is an expert blogger. And of course, our mentor, Dr. Diane Santamaria. And that's it.
Mandy, thank you for that presentation. That was great. Next up, we have Morgan Feldman, and she is an associate professor in the Division of Vulnerable Populations in the Department of Medicine at UCSF, and she's also the associate director of UCSF's Benoist Homelessness and Housing Initiative, and she's going to be talking to us today on provider perspectives on ideal candidates for long-acting antiretroviral therapy for HIV treatment.
Awesome, thank you so much. So as per the introduction, I'm really excited to present some qualitative findings based on interviews with providers to really think about how they process and think through who to offer long-acting injectable ART to. And before I start, I really want to thank the organizers of this event and also a lot of people in the room who I've had the pleasure of working with on long-acting ART projects, both in Max Wise, and STAR and through an R34. So like Maria and Anandi are in the front. Jen, who was the UCSF point person we roped in. Phyllis, who made, none of this literally would have happened without her. Strings that got pulled, thank you. Tara, an incredible doc student who actually has a poster later on today, so please check this out. Liz for running a lot of the data dump. So just all this is to say, Catalina in the back, oh my God, we have stories. So just to say, like, this really is a group effort, so I'm really excited to present on this as like a team, even though I'm the one standing up here. I'm not going to belabor this point. Y'all are in the room. You know why we're doing this. But suffice to say, women, and these stats are for cisgender women. I just want to highlight this specifically. I think when I use women, I use the term broadly. Tend to have worse care continuum outcomes than their male counterparts. And so this is one of the reasons we've been focusing on women. There are many other social structural reasons that this is the case. I'm not focusing on this for this presentation. But I do want to highlight that a lot of the reasons that viral suppression and adherence may be lower range from things like structural sexism, misogyny, interpersonal violence, child rearing, caretaking. There are many, many reasons that are specific to women as to why this is happening. Also in the US, while just under 20% of new cases are among women, as all of you know, worldwide, the number is actually much higher, and women bear the burden of HIV, so it's incredibly important to focus on women, a point I don't need to belabor with this group, but you'd be surprised how often you have to in other settings. So I'm gonna start talking about long-acting ART, just to make sure everybody's on the same page about where we are with this right now. As all of you know at this point, I'm guessing it's 2 intramuscular gluteal injections, and this was approved by the FDA after phase 3 trials where it was non-inferior to oral ART, and so it's now been approved for 4-week and 8-week dosing. And I just want to highlight that it was only approved for people who were virally suppressed, a point that's going to come up throughout this presentation, because it's been increasingly used off-label, and we're seeing studies, including here at UCSF, among people who are not suppressed and showing success in maintaining viral suppression, but I just want to flag that per the FDA. Also, for those who know me, you know this is my soapbox. It is primarily approved in North America and Western Europe, which is a huge issue for equity, particularly given where the clinical trials work done. So just thinking about what that means, and also the interviews I'm done are very specific to the US context. The issues are likely going to be very different in other areas, so I just want to highlight this, and it's something that future research really needs to be exploring. So this study grew out of preliminary research primarily in MaxWise. So these papers here, which I know that the texts are small, but there are a lot of co-authors in the room as well, like Maria, Nandi, Jen, that you'll recognize. So we looked at perceived barriers and facilitators and qualitative interviews with women across WISE, across about 6 different cities. And then this led to an R34, which these data come from, and we looked quantitatively at correlates of women's interest in and willing to use long-acting art. And that paper, actually, Tara, doc student, is leading it. It's under review right now at Jade, so fingers crossed. If any of you all are reviewers, sorry, I just outed myself. Be nice. And so that study actually, there were 15 quant questions, and then we used this to adapt them, and they're now in STAR, which we're super excited about, because as some of you have seen, Women in WISE it's an amazing cohort, and it's unique in certain ways, particularly that women tend to be the median ages in their 50s, and we're really interested in intersections with reproductive health. And so we were able to integrate these questions with the support from Rihanna Nandi, and then Lauren Collins and I are leading that in STAR right now, and so we're really excited to start looking at those data, because one thing I do want to note is when we did this in WISE, it was about a little over 40% of women that said they would be interested in long-acting art, would prefer it, but it's closer to 60% in STAR. So I think partly that is age, it's also just over time, we're seeing a shift towards people becoming more and more interested in it, or at least talking about long-acting art, and I just want to flag this because it is important to demonstrate that there is interest before we start to argue, like, yes, we need people to get it, right? So as a baseline, clearly it's not 100% of people, but we are now starting to see a little bit more than half of people saying they would be interested in it. And then we just had a paper get accepted in AIDS patient care and STDs that, again, Tara is leading. So which is really exciting, looking at clinic level barriers to scaling up art. So a lot of the clinicians in the room, you know this better than we do, but there are many challenges that have come with this that were not necessarily as supported as they probably should have been in many ways. So that is that was informing this, and so based on this, as you all know, clinics are scaling up long-acting art, but there are a lot of existing inequities, both within and across clinics, so it's something that we wanted to flag, and also, as I mentioned, women are really interested in having multiple art modalities, and access is in part determined by medical providers, since they both prescribe treatment and they also help patients decide which modality to use. And so given that, we were really interested to think about, okay, how do providers decide, right? We have the FDA regulations, and there are a lot of, we've seen this when we look at studies of how guidelines are scaled up in a clinical setting. It's a lot of individual decision-making on the part of providers, and we were really interested to think about how they decide, quote unquote, who is an ideal candidate for long-acting art and who they decide to offer it to. So to study this, we conducted 38 in-depth interviews with medical and social service providers across the US. It was primarily the Northeast and the South, and we recruited from clinics that had programs associated with MaxWise, partly to get a geographic variation and partly for feasibility. So we had a point person at each site that helped suggest people. And we also really wanted to have sampling from across different clinics. So often this research happens within large universities. And so we really wanted to make sure that we talked to providers in smaller private clinics and also in Riot White funded clinics. And we did actually, I'm not really describing it much here, but we did actually see differences across clinics, which was quite interesting. With, I would say, the private clinics tending to be a little bit more kind of I know what is best for my patient sort of narrative. And so we really focused on asking providers how they decided who should be offered art and what these characteristics were of these quote-unquote ideal patients. So the interviews were about 45 to 60 minutes, and we recorded and transcribed them, and we uploaded them into Deuce and for organization. And then in terms of coding, we stuck with thematic content analysis, and we really were thinking about differences by provider type and geography. And we focused on provider type because, as you can see on the table on the right, while primarily we interviewed physicians, there was a range of NPs and people in other nursing roles. We talked to pharmacists, and then we really wanted social service providers as well. So we talked to patient navigators and care managers, a social worker, and community coordinators. And then also I want to highlight the majority of people have been providing care for a really long time. So many upwards of 10 to 20 years, which was also really helpful in talking to people as medication options have shifted over time, sort of how they thought through things. So when we asked providers how they thought about who they would offer long-acting ART2, they brought up three primary things. So the first was eligibility concerns. So basically, what is the FDA label and how do they think about that in terms of what patients get offered it? Patients' attendance at HIV care visits, and then multi-level drivers that might affect long-acting ART use, using particularly experiences with oral ART as an anchor. So I'm just going to give a few quote examples from each, and I'm happy to talk more about this in the Q&A. And so providers really talked about how they struggled a little bit because they truly believed that patients with detectable viral loads could benefit the most, right? So there's this idea that long-acting ART is great, but if all we're doing is moving people who are already undetectable from one pot to another, we are not ending HIV, right? Like, it's just the numbers don't play out that way. And so really thinking about if we want to move in that direction, we're going to have to bring people who are not undetectable. Obviously, many of you know are involved in the Latitude study. We're working on that, and then we're seeing increasingly this off-label use. So as some of them noted, as you can see, I'm not sure the label is serving those most in need. And then a case manager in Atlanta said, I don't agree it should only be for patients that are suppressed. The target should be those patients that aren't doing good. So providers really articulated that tension when they were choosing people. And then providers saw the viral suppression requirement as an attempt to make it easier for them. And they really did highlight that, listen, we don't have to make the decision. We just say, these are the guidelines. And so it was interesting that it was not only that, and also some of them were saying, there can be some complex risks for like drug-drug interactions or for risk of resistance. And so keeping it this way actually made it easier for them. So as one provider in Pittsburgh said, I think the viral suppression requirement makes it easy from a provider standpoint. It's very simple. Someone can make that switch without necessarily understanding the intricacies, which is interesting and also a little bit terrifying. But just noting, right, like they understood why the regulations, when the guidelines were what they were, especially as a first pass. And then something else that came up was because, a lot of people on oral ART, if they're virally suppressed, they're coming in maybe every 4 months, maybe every 6 months, but switching to long-acting ART would be every 2 months. Or when we did the interviews, sometimes some of them were keeping patients on every month as well. And so a pharmacist we spoke to in Mississippi was saying, over time we've seen some patients who consistently come to appointments and that would be great candidates because they can't take a pill every day, but they come for appointments and get an injection. And so I think it's really interesting to think about how for so often we've been programmed to think, will they take medication, will they take medication, will they take medication? And now it's switching to, do they come to clinic visits, right? Because that's what we need for the injection. And so it's subtle, but it was interesting to hear providers shift and sort of remind themselves, oh, right, we don't need someone who takes the pill every day, we just need someone who comes to visits. And then another thing that came up was providers really valued how well they knew a patient and how long they'd known them, which is important, and also that benefits a certain kind of patient, right? And so thinking about particularly young people who are coming in newly diagnosed, what might that mean for who gets trusted and who gets offered this medication? So a physician in Atlanta noted, so an ideal candidate, it's someone, they want to stay in care, they're committed to treating their HIV, and they're tired of taking a pill every day, but I can count on them to come in every 2 months. And I don't worry about them too much being lost to follow-up because I've known them for 10 years. Right? And I understand that, right? That is a safer bet, and it means there's certain people that are going to be left out of that group if they're the ones that are being offered it. And then lastly, for this theme around attendance and HIV care visits, is providers really categorize this within 3 kind of subsets, and it was around external responsibilities that could affect clinic visits, organizational skills, like they even just talked about daily planners, and then motivation. So a provider in Pittsburgh said, for a lot of my patients, it's just not feasible because of their work schedule. There was one who was on long-acting ART who went off it because after a couple of months, he was like, this is really hard. Every time I'm scheduled to come in, my shifts change. So I think my ideal patient would be a person who's reliable with a flexible job that's next to the clinic, which, what is that, like 5 people, right? So as I saw that, I was like, that's great. Also, we want this to get out in the community for people. But I think it's that constant tension, right, of like we want people to come on. Obviously, as all of you know better than I do with the pharmacokinetic tail, like we can't have people coming in at varied times, and also it does limit who would be offered it. And then lastly, around motivation, someone said, the ideal candidate to me is driven, really interested and motivated to do it. And the patient is actually the one that drives that decision, which is huge, and I just want to underline that again, right? The patient is the one that drives that decision. So really thinking about this as shared decision making. Even the patients that have poor adherence, they really want it and are committed to do it. So thinking about how to suss that out with the patients and really thinking about what do they want and what is most beneficial for them and what do they feel they can take on, versus sort of driving what may be best in this, medically and not actually feasible in their daily lives. And just briefly as an aside, I know a lot of you have studied this, is I also am afraid that this is going to create this narrative of, well, we gave them this and they didn't do it, quote, the right way, it is their fault. This sort of reiterating some sort of narrative of the patient not doing what they're supposed to do versus meeting the patient where they are and actually saying what is best for you, what is feasible. All right, and just for the last one, thinking about the multi-level factors that affect art use, providers really talked about long-acting art as a potential solution to some of these social structural inequities that made it harder for patients to adhere to oral art, so things like housing and substance use. So a provider in Jackson had a patient who used opioids and talked about that person's life is very disordered, and said the patient herself said to me, I'm terrible at taking pills, and I was thinking, wow, wouldn't it be nice if I could just give her a shot? But I'm in no way convinced I could find her once a month, so I'm not offering it to her, and it makes me sad. It could potentially serve her purpose so well, but I just won't do it. And so the providers described this tension of really trying to figure out what patients could benefit and not actually being able to, or having the resources, particularly providers in places like Jackson, to go out and meet them. And obviously this is not easy, but easier in more well-resourced settings, but unfortunately Jackson is not one of them. And providers also talked about gender-based differences, and they really did talk about women as being the ones that were more organized, more motivated, more likely to come. And they also said, too, because of histories with birth control, even just taking a daily pill, or particularly those with a history of depo, that it might be more feasible for women. As one provider noted, I think if women are on shots for birth control, they can say, well, this shot is like the birth control shot. In fact, they'd be more used to long-acting preparation and perhaps will understand the concept. This was also something that providers thought through. All right, so in conclusion, there really were disconnects between the patients who providers thought could most benefit and who were clinically eligible. And interestingly enough, we actually found similar things when we interviewed women ahead of this. So this was probably 4 or 5 years ago in Weds, and said, who do you think could most benefit? And they actually said, people who have childbearing responsibilities, people who are unhoused, people who are using substances, and of course those are not the ones who are eligible, depending on viral suppression. So there was a synergy there. And then providers also noted specific characteristics that could make them strong, could make a patient a strong candidate. So this included regular clinic attendance, people who were organized, motivated, had a history of injectable birth control, and then long-term relationships with providers. And one other thing that came up that providers were struggling with was they didn't want to use long-acting art as this carrot, saying, listen, if you become undetectable, we'll give you this drug that will make your life easier, because they really understood that this started bordering on paternalism and could really set a dangerous precedent and a dynamic among the communities they worked with, but really did want to get patients on. So it was something, there was no answer, but I'm just sharing this as something that came up as a tension. And then lastly, future work should really think about talking to patients who have gone straight on, even who are not suppressed, or, and so really thinking about their experiences, and also patients who started and stopped, I think is the other group too that it's important to talk to really think about how they have continued discussions with their providers. So the last slide, just in sum, clinical eligibility was important, but it was not the only factor in determining whether a patient should be offered long-acting art, and providers incorporated factors such as patient care engagement, sociostructural barriers, and co-occurring health issues. And there was a gap that frequently emerged between providers' perceptions of who they called an ideal candidate and people who face significant barriers to adherence and could thus most benefit. So thank you again to the people I've mentioned, to the NIH funders, and to the providers who took the time to be interviewed. Thank you.
Thanks, Morgan. It's a great talk. Our next speaker is Bill Short. He is an associate professor of medicine, infectious disease specialist, I'll add that, from the University of Pennsylvania. And he is going to be talking about the Antiretroviral Pregnancy Registry, 30 years of monitoring for congenital anomalies.
Great, thank you. And thank you for everyone who stayed till the end. I am the final talk before you have your break, but this is a very important topic, and we're going to switch gears and talk about pregnancy. So as she mentioned, the talk is about the Antiretroviral Pregnancy Registry and looking at 30 years of following up for congenital anomalies. So in terms of background, I think in general in the United States, we think that there are approximately 3,500 women who are pregnant per year. There was originally 5,000. That number was down estimated by the CDC. I will say, and it's done on these slides, that we estimate about 25 to 30% of those exposures are reported annually, so we have a lot of work to do. The registry is an international prospective exposure type registry. It actually started in 1989 after the discovery of zidovudine, so it's been around for a very long time. And it was to meet post-marketing commitment. I do have to put the glasses on, it's very small print. There are currently 24 sponsoring ARV manufacturers, and it's overseen by an independent advisory committee. And in disclosure, I am one of the advisors to the pregnancy registries. And really, this registry is designed to assist clinicians and patients in weighing potential risk and benefits of HIV treatment during pregnancy. One thing many people don't know is that there also is other parts of the registry, and it looks at those who have hepatitis B, pre-exposure prophylaxis, as well as post-exposure prophylaxis. So these are people without HIV. I think everyone thinks of it as just HIV, but there are other things. And you'll see when I show the reports, they're actually much lower. And so right now it looks at 198 ARV drugs, 60 are brand, multiple combinations, and 138 generics. And there are 3 objectives to the registry: to provide early warning signals of major teratogenicity, estimate the prevalence of major birth defects and compare it to general population, and then finally to supplement all the data we have when a drug receives FDA approval. The methodology is really important, and it's really misunderstood by a lot of people. There are 3 ways reports can come in. The first way is what we call the prospective reporting, and that's what we include in the primary analysis. And what all the prospective report means is that you register the patient before the outcome. So you have to have sent in your report of who the patient is, what antiretroviral they're on, before that outcome is achieved. And that is, again, all voluntary. What happens is when that paper comes in, it is sent to a dysmorphologist, something I had never known what that was. There's someone whose job is strictly a dysmorphologist. She's at UT Southwestern. Her name is Angela Shirley. She knows every birth that you can imagine. She knows every syndrome that they're all associated with. And then they're going to be compared to 2 population comparators, which I'll share with you in a second. In order to be included, you have to have a birth outcome of greater than or equal to 20 weeks with 1 or more defect. There are 2 other ways that the reports can come in. One is through clinical studies, so these are things that are done through clinical trials. It's from the manufacturer, they're reported in, and a lot of times there may be overlap, but that's all figured out within the coordinating center of the Antiretroviral Pregnancy Registry. And then the final way is retrospective reports. So that means you submit it at the same time, you register, and you give the outcome at the same time. And I'll show you that is not included in the primary analysis. So here are analytic methods. I told you all 3 ways. No matter which way they come in, basically we look at timing, dosage, the type of antiretroviral, concomitant use of medications, outcome, and birth defects at the time of delivery. So if you go all the way to your left, you see the primary analysis. It's very simple. You just look at the number of defects over the number of live births, and then they compare it to 2 population comparators. Early on, it was just 1, and they really needed to expand it. So the first one is the Metropolitan Atlanta Congenital Birth Defects Program, where the rate is 3 per 100 live births. They added the Texas Birth Defect Registry for many reasons, and there the rate is 4 over 100 live births. And then they compare first to second and third trimester. One thing to note, and I'll talk about that when we talk about dolutegravir, is for first trimester exposure, it does not differentiate if it's it's just anywhere within the first trimester, and we'll come to that in a second. And then for the latter 2, they're just really reviewed. So review all those other cases that come in through studies or retrospective, look for patterns, but again, they're not included in the primary analysis. And this is really what I mentioned. You need to know the timing of the drug exposure. And I think this is one of the hardest things as someone who reports, is to try to figure out where that happened. What did the patient come on? Was it preconception exposure? Where did they actually start? Because obviously there's a timing that is important, right? The first couple weeks are critical in terms of organogenesis. You need to have accurate stop and start dates, gestational age assessment, and I really want to hone in on the last part, because I think this is important for counseling, and a lot of people don't understand that. People look at the registry and say everything's safe, but what is safe, right? So I think these 2 graphs, and this was a paper written by Heather Watts years ago, and I think it's important, and as Liz Lowenthal mentioned, understanding the epidemiology is so important. So when you look at a sample size of 200 exposures, so when I go through the primary analysis, you'll see, and the one thing that's going to stand out, we're talking about long-acting injectables, how important they are. Cabotegravir is not on there. Why? Because it has not reached that 200 threshold. You need a sample size of 200 exposures, because that provides 80% power with a type 1 error rate of 5% to detect a 2-fold increase in overall defects, and that's those that have a prevalence of 3%. So that's overall. You'll notice, and I bring it up in the next slide, that's not a neural tube defect, which is rare, with a prevalence of 0.1%. There you need 2,000 exposures to detect a threefold increase. One thing that people say often, and it's wrong, you're not ruling out, you're detecting. Remember, sample size and power, you're trying to detect, and that's what you use a sample size for. So keep those numbers in mind when I get to the primary analysis. How many people do not remember? It's a double negative, so it's pretty bad. What happened with dolutegravir in 2018? I think anyone in the field knows what happened. It was a hot mess. And so this is why I think this is important, a little bit of a bias. This presentation is one of the most important ones, because we don't want to go back to that. So this was done, the SIPAMO study in Botswana, looking at birth defects. They were really focusing on efavirenz. And what they did is for analysis, and I remember where I was, as we all do, probably when this hit the press, and there were 4 neural tube defects in 426. And you don't have to see, you don't have to understand about biostatistics, anything. You can see those rates, they were much higher. So there was some signal, and this was with preconception exposure to DTG. And so started all the different craziness that happened. This slide, courtesy of Lynn Moffison, who, if everyone knows her, is wonderful. She makes these slides on the plane home from whatever conference she's coming to, God love her, and shares them with the world. But I think the upper left really shows you what happened, and really should stress to you the importance of reporting. Reporting. Because if you look at March of 2018, your N was 494, and there you see your prevalence was 0.94. And look what happened over time. It took 4 years, but with exposures, look at the exposures, you got all those numbers, that prevalence came right down. It really mirrors everything else. So I think the take-home point is we need to increase reporting to the pregnancy registry. Here's the result. So when you look at the majority of people who report, it's largely infectious disease, and they sort of lump together HIV providers. So I just think it's anyone who is not OB, peds, or family medicine. They lump them in there. Then its next follow is OBGYN and family medicine. And you can see all the way down, there's a whole host of other people who report, but largely it's those 3 that are the reporters up there. There is something called 100% provider on your right. That is someone like myself who commits to reporting every single case that I have. The one nice thing about being 100% provider, because we're all busy, you don't have to report the registration and the exposure. They allow you, because I have committed on paper that I will give them all of my cases, I can submit them all at the same time. So that's the one benefit of being 100% provider. Here's the primary analysis. You can see the total number of pregnancies enrolled to date are over 26,000. Obviously, there's always pending outcomes, and then there's lost to follow-up. And so you can see somewhere around 85% of evaluable pregnancies. I don't have to go through all the different pieces here, but I think the piece in the middle, if you look at this, is still largely HIV treatment. You know, we still take care of patients who have pre-exposure prophylaxis, post-exposure, as well as hepatitis B. We're not doing anywhere near what we need to do in terms of reporting those, and we have plenty of people on PrEP. And the one thing that just stands to mind is cabotegravir use, people who are getting injectable, and we're not reporting them. Majority of the cases come from the US. However, what you can see is reports have come from 75 countries. And there is no restriction on what you report. As long as you can report, you're able to do that. But most of it's from the United States. And you can see here, earliest trimester exposure, largely first trimester. Again, not really taking apart where that was in the first trimester. It's just the whole first trimester, followed by second, and then a smattering in the third. And largely, most of these are live birth. I think one of the barriers to this is not many people tend to report spontaneous abortions. They tend to just leave that because they know they're going to get a lot of paperwork and they don't always have the answers to it. So here's part of the primary analysis. So what you can see, looking at first trimester, the number of live births, birth defects with a prevalence rate of 2.9%. And then the second and third trimester, they lump together, because obviously, remember, first trimester is your period of organogenesis, and really where your concern is, 2.9%, and your relative risk of 1.03. And then they looked at any trimester, which is 2.9%. And this is updated every 6 months. And again, so highlighted in red are the first trimester APR, and then any trimester. And you can see the number of exposures there is very high in the thousands. One thing I just draw your attention to, if you look up and down at all the different drugs, you'll notice, as I said, cabotegravir is missing from there. And why is that? Because we have, to date, about 10 exposures reported to the registry. And you just showed, when was that? 2021. So we're now going into 2024, so 3 years, and we're nowhere near that 200 mark to show that it's safe. And we could talk about that during the question and answer period, about use of something like this for people who are potentially could benefit during pregnancy. Just going up and down, you don't really see there's anything that stands out here. If you look at the registry, there are 2 drugs that stand out. One is didanosine and one is nalfenavir. You see their prevalence rate are a little higher than the MACDP, but not the Texas Birth Defect Registry. Why is this not called out? For a couple reasons. Not many people are using, I hope they're not, DDI and nalfenavir anymore. Very few reports come in. As a matter of fact, there's not been a report to the pregnancy registry in about the last 8 to 10 years for these 2 drugs. We've also analyzed the defects, even though the prevalences are higher, and there's no pattern in there. So it's unclear why those rates are so high, but because there's no increase in reporting, nothing else is done about it. I have to read this because I'm part of the APR, and every time we do a presentation, you must read this. And I think it's important because it gives you a little bit of the limitation. So in reviewing all reported defects from the prospective registry, informing clinical studies and retrospective case of antiretroviral exposures, the registry finds no significant increase in the frequency of birth defects with first trimester exposure compared to exposure starting later in pregnancy, and no pattern to suggest a common cause. While the registry population exposed and monitored data is not sufficient to detect an increase in the risk of relatively rare defects, these registries should be used as they are recognized. The registry is ongoing, and given the use of the newer therapies about which data are still accumulating, healthcare providers are strongly encouraged to report eligible patients to the registry, and all the contact information is there. Again, the key contributor, and here's where I get on my soapbox, as Kate knows, I've hit her up too. Really, it's important to have healthcare providers reporting to the registry, right? There's no other way to get this data, and we've tried everything from trying to have patients report themselves, but it can't. It really resolves and falls on us to report to registries. One thing that's not in here is the length of time from a drug when it's FDA approved to get that 200 mark, and it's somewhere around 6 to 7 years. And as you can know, I think the best thing is bictegravir. Bictegravir was approved in 2018. It just got the 200 mark. And the number of pregnancies that have come through with someone on that without data has been growing and growing. Just to acknowledge, you may know many of the people who sit on the advisory committee, and then really thank the efforts of all those who submit to the APR, because it couldn't happen. And then I'm going to put my final plug in. So if anyone is interested who's not a reporter, please find me. I have a way that I could pay you personally per report that you submit. We have a study now, it's been going on for about a year. I've been able to get 60 new prospective reports in. So if you are interested, come find me. And my last plug is, once you do this, it takes me 5 minutes to report a case. It's just that easy. And we just went back and modified our enrollment form, because we're like, what do we use the CD4 counts for? We don't use all this stuff, so we really are limiting down to exposure outcomes. So we're trying to make it easier and easier because we need to get those numbers. And that's a contact, and thank you very much.
Thanks, Bill. The floor is now open for questions to our presenters up here.
Hi, everyone. My name is Jalen. We appreciate the community-based project that you took part in, Mandy. We also have something similar that we're doing in Syracuse right now. We're called Layla's Got You, so everyone can look us up on Instagram or Facebook. My question to the panel is, we're always looking for more research to engage in the community, so how do you guys plan to integrate that for completion?
Jalen, could you repeat that question, please?
My question really is based
For this study or just research in general? Okay, so thank you for the question. We have a community advisory board for our population health and emergency medicine section with our Texas Emergency Medicine Research Center. Because a lot of our work is focused on cisgender Black women in PrEP, we have a PrEP provider who's a Black female physician. We have a social worker and community advocate. She also leads the Texas Black Women's Health Initiative as a member. We have an HIV positive woman who is an advocate for HIV prevention with Black women. And I am missing somebody. Oh, yes, we have, I know why I'm missing her because she works for UT Health, but she is very well known in the community. We had an issue with paying her, y'all. They didn't want to pay her cap fee because she works for UT, so. But she's been doing it voluntarily. We do plan to replace her because we have the budget funds on different projects to support that cap. But we have found their input to be really important. We have some other studies where we've created cabs in different areas, and their input is just so different from the investigative team and the community because they're in an advocacy role. So that input is really important in shaping the kind of research that we do.
Hey, can I just add, I think also as part of the AIDS clinical trial group, so the CAB's involved, you know, a lot of times when a protocol is done, there's not much you can do, but I'm on a protocol now where we're looking at the use of long-acting injectable in postpartum women. And one of the key presentations is to take that to each of the Impact Network, to the ACTG, to the CAB, the Community Advisory Board, and get their input. And I've been on 2 calls now, and a lot has been modified based on community input, one including age. You know, the first question is, why are you limiting that age to 16? There's 15 and 14-year-olds who are getting pregnant. Why are you just stopping? And that was all as a result of community. So community is definitely involved in every aspect, and they should be. And if they're not, in some place you need to evaluate why. It's really critical.
Yeah, I would also just briefly note that a lot of the large clinical trials groups that you're hearing all this sort of acronyms thrown around, a lot of them do have community advisory boards, and I will say I think there's been a shift over time between using community advisory boards as somebody that we take things that are already formed to, and a group that actually is actively deciding where the science goes, and I think that's an incredibly important distinction. And it's really, I think people are trying to move more towards community-based participatory research than as having the community advisory boards be more as a sign-off. The other thing I think that shifted in this, well, I won't say past tense, is beginning to hopefully maybe kind of shift is, I think as someone who does a lot of qualitative research, it's sort of been ingrained in the way that we do work. And I've now started to see large epi studies that are secondary data analysis only start to involve advisory boards, which has been really helpful and interesting to see. It's new. And I think sitting on NIH review panels, we're starting to see reviewers actually say, like, I know that this is secondary data and this is important, and at all stages, from the beginning of what the variables are, all the way up through how do you interpret results, and through dissemination. So I'm hoping there's a little bit of a sea change, because if we have it happen in the review panels, you know people are gonna make the changes because they wanna get the money. So it's helpful, I think, that it's at least we're starting to get that push, because your point is very well taken, that it's super important.
Yeah, I'll just add one last thing. I think in the space of ID or HIV and substance use in our community in Atlanta, I've spent a little bit of time with one of the harm reduction community clinics, Georgia Harm Reduction Coalition, which is doing some awesome work. I think one of the challenges that I've heard from them and also from the health department is a lot of, there needs to be a lot more community engagement, but at the same time, a lot of the community programs sometimes feel like they're approached a lot by academia for research purposes to use their data. And so I think it's been a really interesting experience for me to approach as a learner, just to sort of learn what their needs are and to understand the landscape better. But I have seen how various academic programs and community programs have worked together to do really awesome work, so I think it's definitely needed.
The bars not fully set up yet, so I was just gonna say you're stuck with us for at least like 5 minutes until you're there.
Thank you all for your presentations. This is for Morgan primarily. So in your discussions with providers and thinking about sort of LAI art, did they sort of in any way talk about the role of mobile units or the ability to sort of think about using mobile units to sort of fill in this gap in the event that they could not find folks, or, you know, where they sort of felt, or how successful they felt like that might yield results?
Yeah, I really appreciate you asking that question, and I think it's actually something that providers did talk about more in cities in the Northeast, simply because of resources, which is not surprising. I mean, even I was doing my dissertation in Baltimore, and providers used to half joke, like, well, we just tell people to move to New York, right? That's where the money is. And I think there are some logistical challenges around cold chain storage, around getting blood results back, you know, making sure people are where they say they are. But it is something that we've thought about. I know Jen has been doing work on in pharmacies, and thinking about doing injections there. There's some studies that are starting to look at whether partners can do injections. So I think we really are trying to think about ways to get it out into the community to make it more feasible. And I think it's been really interesting to see, I think with COVID, there was a little bit of a shift of really showing on a broad scale how we can get immunizations out to, for example, you know, migrant farm workers, people who are using drugs, people who are unhoused. And so there is a proof of concept there that, like, listen, it's not that we can't do it, we just need the money. So it is something that providers have been talking about, yeah, so thank you for raising that.
I just had one question for Wendy, and it was on your presentation where you showed the prevalence of use of the different substances and tobacco. And I was really surprised about the big difference in, you know, women reporting tobacco use in the Ys and the star. And I was wondering if you collect data on like vaping, or is that part of, you know, one of the questions on your survey?
Yeah, this is a good question. For this purposes, it was specifically for the question that asked about daily cigarette smoking, for that tobacco use question. I know they ask about e-cigarettes, but I actually can't remember right now if they ask about vaping.
Do you have any thoughts about why there's such a big difference?
I don't know. I do wonder if over time, I guess it is asking about use in the past year. I do wonder if over time, you know, the sort of attitude towards cigarette smoking has declined over the years, and if maybe people who are, you know, with a mean age over 50, maybe who have been smoking for a lot longer, if that could impact it. But I'm not sure. I think it's a good question.
Thanks. Okay. I think that concludes this session.